You. All right. We're going to bring our panel up now. That's all the presenters from this morning, including Ms. Christian.
Thank you.
If you'll please, Dr. Ahbar, Dr. Chopra. Linda, is there anyone that I'm missing? Dr. Pat Crowley. I didn't hear what she said. Dr. Sammy. Grab him and pull him up, please. All right. So we have a limited number of microphones, so we'll have to be sharing. Please take wherever you're comfortable. If you want to go front and center, you just push those guys out of the way. Absolutely.
Well, it's all men, so I should sit in the middle, right?
It'll draw their attention to the middle, yes. All right. Does anyone here a baseball fan besides Marcus Elsegood? Hands. Anyone here a baseball fan? All right. I'm a Chicagoan. Obviously, I'm a Cub fan because is there another team there? But I'm also cognizant that possibly the greatest team in baseball to ever play the game was the 1927 Yankees. And if I could have a signed baseball from the 1927 Yankees, that would be like gold. I mean, it'd be like platinum. It'd be amazing. Well, today you have the opportunity of having your own version of the 1927 Yankees baseball team signed baseball. We are auctioning off 10 the LDN books. Come on, you can come up. Don't be shy. We are auctioning off 10 of these that'll be signed by everyone who contributed to the book who's here today. This will be an auction. That means that I'm sure we'll have some kind of a minimum. They haven't told me what it is. We want to generate, obviously, more than $27.99 per book and more than $20 per book because these will be limited editions. And there's only going to be 10 of them in the world of these signed first editions of the LDN book. So please keep that in mind. Go to the ATMs, load up on your cash. Be sure to make sure you know how to use a PayPal because we will have you active today. So, all right. Again, we're asking for questions from the audience, questions from those attendees online in the live stream. Please email to questions@LDN2016.com. That's questions with an S at LDN2016.com. Those of you who do have more questions besides the multitude I have in my hands, please write them out, put them up in the air, and one of our volunteers, Nancy or Sarah, will come by and grab them from you. All right, these are open. I'm going to ask you all to try to keep your responses as brief as possible because we have a lot of these to cover in a relatively short period of time. We've got about a half hour, which is more time than we've ever had before for Q&A of this nature, but we have a lot of great questions. First question, steroids and LDN. Any thoughts on interactions between the two drugs? Very briefly. Steroids and LDN, any thoughts on interactions between the two drugs? Doctors? No thoughts.
Don't look at me.
Well, my thoughts are if people are on steroids, and they are very often in autoimmune conditions, you would feel that the effect of the LDN would not be as effective. And sometimes that seems to be true, but not always. So, you're going to go ahead anyway and give them the LDN, but get them off or reduce the steroids to as low a dose as possible. That's my approach.
Okay. As a pharmacist, there's no direct drug-drug interaction between the two. Certainly in this utilization, I agree with Dr. Crowley, and my clinical experience shows that as well. Skip, do you have anything besides that? Have you seen? Anything below 20 milligrams of prednisone in conjunction with LDN does not represent a problem? All right, if you're decreasing the dose, it does not appear to be an issue. Dr. Weinstock, in sarcoidosis, the four patients that you described, were there any biomarkers tested before or after?
The first patient had an ACE level, but that was low to begin with, but there were other chemical markers that I've become aware of since then, but I have not measured them.
Okay, thank you. There appears to be a very high placebo response in pain and ulcerative colitis. Is there any simple explanation here?
Absolutely not. I mean, that's why all the studies now include an arm of, or investigative mode of looking inside. Placebo is amazing. And irritable bowel studies, it's 30 to 40%, and in some studies. And then depending on how you grade the needs to respond, in fact, in some Crohn's disease, it's been up to 30%. And it's why GI patients are tough to study.
Okay. Again, Dr. Weinstock, you're Mr. Popularity right here now. Are you also using LDN and celiac? Yes or no?
No. The answer is most patients get into remission. If they're not, it's often due to bacterial overgrowth, but sometimes permeability issues need to be treated specifically. And I wouldn't discount it if I've tried everything, though.
Just for my own curiosity, are you also using probiotics in conjunction with these protocols? Probiotics?
Probiotics after I treat SIBO. So after antibiotic therapy, then I'll give probiotic, zinc, L-glutamine.
All right. What about Saccharomyces boulardii for large intestine at all, or no?
For S. boulardii, I use for patients prone towards diarrhea and all who have been affected by C. difficile to promote bifidobacter growth.
Okay, thank you. Dr. Khan, LDN and myofascial tissue, oh, maybe that's a different, okay. As a cancer preventive, should we take LDN every day, and if so, what dosage?
Okay. Nobody knows yet. That's just all theory. The dose that I would recommend would be, again, in the same range of less than 4.5, but we don't know whether it should be taken continuously or intermittently. This is yet undefined.
Thank you. Whoever put that question, they also had LDN and myofascial issues. In the next next Q&A, I'd like a clarification on that, please. In SIBO and restless leg syndrome and Crohn's patients, after acute conventional treatment, is LDN given indefinitely? Good question.
I do. Well, let me just say, in Crohn's patients, I reported actually increased incidence of RLS in Crohn's patients and in celiac patients. And once those diseases are treated specifically, the symptoms get better. So treat the underlying condition in all secondary phenomenon, and then you won't necessarily need the LDN, although especially in celiac. In Crohn's, you may wish to continue it long-term just as a suppressive therapy for their inflammatory bowel disease.
Okay. As a PharmD, that means I'm a doctor, which means I'm also entitled to have the worst handwriting on the planet. I'm going to encourage all of you, if I have to read stuff, to bypass your doctor impulses and print really, really carefully, because I'm having some difficulties, so I apologize. I can't ask the other two questions on here. What were the adverse effects that led to discontinuation of LDN? Anyone? What were the adverse effects, the adverse drug reactions that led to discontinuation for LDN? Dr. Weinstock listed 3. Dr. Khan listed several. Dr. Chopra, you listed several as well. So let's just do bullet points on these, please.
Yeah, insomnia or very bad dreams.
Dr. Weinstock?
In addition, headaches and jittery feeling.
Dr. Chopra?
I don't usually stop them on if they have these symptoms. These dreams are colorful dreams, then the headaches, the insomnia. These are all transient. So the trick I do is I start them in the morning. So I start them at 2.5 milligrams in the morning for a week, and then after a week or maybe even 2 weeks, I then go to the full dose again in the morning, and then after a few weeks, I'll have them switch to a night dose. So in most cases, I can actually bypass these side effects, and these are temporary side effects. Remember, we are treating really complex conditions. These are really complex conditions that have failed conservative other treatments. So having a headache or a colorful dream, a free movie every night is not a bad idea.
Dr. Khan?
Just one more comment that for us, we use dose escalation, so it does the same thing. So it's rare that I would actually have to stop the LDN, but we might have to back off the dose if we go up too quickly.
I think Dr. Chopra addressed it briefly. We had the question a number of times about dosing times, nighttime versus morning time dosing. in our practice, and I'm sure in others, we'll quite often switch a person to a morning dose temporarily. Does anyone have a guideline if they have those nighttime problems? Does anyone have a guideline of how long it typically takes before a patient is switched back to nighttime, or is it necessary to switch them back to a nighttime dosage? Dr. Crowley?
Well, technically, you see, Dr. Bihari's idea when he started using naltrexone was it increased our endorphins. We all know that, 200 to 300%. Well, now your endorphins are produced during sleep. 90% of your endorphins are produced at 4, 5 o'clock in the morning. Now, a little in the afternoon as well, but most of them are. So that was the rationale for doing the nighttime dosage. And I still use that rationale. So if we have a problem, which we do sometimes, with disturbed behavior, you put them onto the morning dose. You just wonder, are they getting the same effect in the morning dose? So I prefer to go back to the nighttime dose, but sometimes it's not possible because they get the symptoms back again, so you have to leave them. And a lot of these patients seem to do okay, so I just don't know. But the rationale was to have the evening dose because the endorphins. Now, what I find fascinating is Dr. Bihari, and I knew him personally, and he felt that the endorphins were the key to the whole immune system. I wonder what he'd say today if he was listening to what we've heard this morning and all the new science in relation to the work of LDN, its anti-inflammatory and various actions. I think it's fascinating, and it's a whole new, and it's a whole new area. But I mean, the nighttime dose is in my preferred dose, that's for sure.
Thank you.
One comment.
Yes.
There's one comment on one of the side effects that we do see occasionally is gastritis. Patients are asked to take this on an empty stomach, and very rarely they need to switch over to a paste that can be applied topically in case they can't tolerate pills. So that can be resolved also.
In previous presentations, it's been suggested that sublingual dosage is an optimal. I think Stephen Dixon from Scotland, you've used that quite a bit. Strictly with pediatrics or sublingual with adults as well? Sublingual with adults as well. So that's certainly a way to
reduce the likelihood of gastritis.
Stephen, we need to keep it real brief because we can't hear you from the audience. I apologize. There's opiate receptors in the bowel, so it may have a greater impact there. So, but yes, it would certainly eliminate one of the sources of gastritis. Skip, do you want to weigh in on this at all? We're going to the pharmacist here. Well, Dr. Lenz recommends using a transdermal over a sublingual because he feels a certain percentage is going to be swallowed. 80% is possible to be swallowed, and that would then, of course, not take care of the gastritis. So again, we have clinician variances here. This is a question I think that's open to everyone here. Are the publications that you listed in your presentations open access? Can the people in the audience obtain them readily? Anyone? Yes, no? Dr. Khan?
I only have one publication on LDN. It's open access.
Okay. Dr. Weinstock?
Certainly, and just PubMed, PubMed.com is a fantastic resource just for putting in
Yeah, it was
nomenclature.
mentioned Medline, and that's also accessed pubmed.gov. For those of you in the listening live stream who are not familiar with this, it's the National Library of Medicine. It's a wonderful resource. It's completely free, and it has virtually an abstract of virtually every publication from a peer-reviewed journal that's listed.
I do have a question about
Yes.
the nighttime morning dosage. Certainly, just physiologically, you're going to have more endorphins at night. But when you give LDN, aren't you supposed to boost enkephalin 15-fold, 12 to 15-fold anytime after it's given? So what's the difference? If you give it in the morning, you're getting more then. Are you going to have a negative effect just because you happen to have physiological endorphins at night? I'm just not sure about that. I've found that the acceptance rate and side effect profile is less in the morning, so I'm just happier with it. And then I've tried to look at the patients who failed or were succeeded in treating their Crohn's Crohn's, ulcerative colitis, and RLS, whether they took it at night or morning, and it didn't make a difference. It was halfway.
Thank you. Thank you. Dr. Chopra, on the question of access to your references?
I have one publication. For chronic pain conditions, there have been two publications, one on fibromyalgia by Dr. Younger, who's here, and I have one on the use of LDN for treating complex regional pain syndrome. And I think there are a few more that are coming out on the use of chronic pain, but again, the best and the most reliable source is PubMed.
Again, for resourcing these, there's a wonderful tutorial at pubmed.gov to use the website. It's very straightforward. It'll take maybe 15 to 20 minutes to get yourself fully acclimated to it, and it's a fantastic resource that you use for many years in the future. This is a real open-ended question, so we may or may not be able to answer it completely. Why do you think fatigue is the main symptom that consistently is improved with LDN? Now, I don't have 3 hours to answer this question, so let's just throw out, without a lot of commentary, one or two ideas from those who are interested.
I'll take that.
Okay.
So fatigue is, again, in chronic pain, fatigue is a big issue, and sometimes it's a bigger issue than chronic pain itself. If it depends, I mean, what the reason for the fatigue is, but if it's because of pain, obviously, if the LDN is working for pain, it helps with the fatigue. Again, the simple solution is, yes, you're getting endorphins. Your endorphin levels going up, and it's helping you get more energy, and it takes care of the fatigue.
Okay.
I have a very interesting anecdote for Dr. Chopra, which relates to this question. I have chronic pain, my back. I don't even want to take an x-ray of it. I don't know what's going on in my back.
Once again, that fear factor.
Yeah. Anyway, I don't take LDN, but what I find is when I exercise vigorously on a regular basis, which I try to do, the pain goes away. And so I wonder if there's a relationship between the endorphin levels and the exercise that's contributing to the relief of the chronic pain. And the other thing is, when the pain hits, I feel it as fatigue. I don't actually feel the pain because I do karate, and so we're trained to turn off the pain, and so it manifests as fatigue.
I want to ask Claudia a question, since I have read everything you've ever written, except for the new book that hasn't come out yet, and I'm now a fanboy. I've seen almost everything you've ever written. But
You're my one fan. Great.
You're one, right. There's another one, my producer, was also a big fan. At any rate, Claudia, I know that in your personal life you've had some experiences with pain, and you've now used naltrexone at the higher doses. Have you found any reduction of the pain associated with the naltrexone at the higher dose?
I, first of all, completely agree with you that when you are in pain, you've got to just suck it up and work out, because it really not only releases your natural endorphins that you produce, but it seems to just, I don't know, get the juices going, and it makes you feel better. And it also combats fatigue. You got to keep your body moving. That's very important. I found that the side effects at higher doses, this is some of the problems, is when you don't take it for a long time, which is why I'm taking so many notes. It's so interesting. When you don't take naltrexone, let's say you're sober for 8 months, and suddenly you take 50 milligrams, you feel it. I mean, you get dizzy, some people get nauseous, some people get, headaches, sleeplessness, sleepiness. So you really have to sort of start back again at 25 milligrams, and you have to eat a full meal, unlike what you're saying on an empty stomach. So there's such a complex variety of individual response to it, but I've found in my own personal life that yes, it definitely did help, and I've been I'm very interested in the lower dose, because the higher dose definitely blocks off a lot of things. And there have been studies that over long-term use of high dose, people can get depressed and so forth.
And I've had a lot of conversations with patients who have alcohol AUD, and and they failed with some of them have been successful with AA, and others have been unsuccessful with AA. And this is something that is very, very controversial, and people get really violently angry when you bring this up.
But see, this is the thing, is it's not a my way or the highway thing, and just very quickly, I'll tell you, I met with one of the big honchos at AA, and he's very interested in allowing people to become sober on naltrexone and then go back into the AA. And at that point, they're saying, we don't care how you get better, just get better. There's got to be a more open-mindedness about this. You can't be my way or the highway anymore. Too many people are still dying.
Thank you. Dr. Chopra.
Yes, I have one little thing on that. So there've been studies that have shown that ultra low dose naltrexone can help AUD. And I was just talking to you about
Yeah,
that.
it's interesting.
So 0.1 milligram is as slow as that. And the pharmacists have told me that they can't make it a pill. There has to be a liquid. And 0.1 milligram per day is all you need to help with alcohol addiction.
It's amazing. Never
That's
heard
all you need. So in case 25 milligrams is too high for side effects, or 50 milligrams is way too much for side effects, 0.1 milligram might just do the job.
We're finally bringing Claudia back in the fold of low-dose naltrexone. Dr. Khan?
That's actually what I was just going to say, is that I was wondering if low-dose naltrexone might be a more effective treatment for alcoholism than high-dose naltrexone. And it looks like Dr. Chopra just answered my question.
Wonderful.
Actually,
Thank you so much.
Just one more comment, that on high doses of naltrexone, there is a significant suppression of the immune system. And you're very much more likely to get infections, which is exactly what you don't want alcoholics to get, because that is what they will succumb to, the infection.
On the other hand, if they get the alcoholism under control, they stop drinking and they stop using naltrexone. Because it's targeted, you don't take it once you're done with it, you're done with it. So
But it does suppress the production of every kind of immune.
that's interesting. At
yeah.
what dose, though?
At that 50 or
At
100
50? At the
milligrams.
At the therapeutic dose, yes.
Yes, very
Really?
high.
Yeah.
That's
Okay,
something
do any
to
of our
say at
speakers
recent
have
meeting.
experience with low-dose naltrexone in conjunction with vitamin C infusions? No? Yes?
Well, we use it routinely with vitamin C infusions because we have an integrative practice. Our naturopathic doctors prescribe the vitamin C, and I prescribe the LDN. We don't have any specific data. I'm not sure what the person's asking. I don't have data to say whether they're synergistic or not, but they're highly compatible, and it makes good sense to combine those two.
I think that's a satisfactory answer. Dr. Chopra, please.
Yes, I think vitamin C is a great idea to take, especially for very chronic neuropathic pain conditions. Vitamin C is a free radical scavenger, otherwise known as an antioxidant. Now, one of the things that happens in patients with chronic pain is that we produce free radicals, and I can go on this subject for an hour.
But I only have 12 minutes, doctor.
I know. So vitamin C, in fact, there have been 2 studies that have shown that vitamin C given preemptively to patients with fractures, one was on arm fractures, another one was on ankle fractures, can actually prevent these patients from getting into chronic pain. So I think it's a great idea to use vitamin C along with LDN.
Thank you. This one, I guess, is sort of a case study. Patient had to stop LDN, was instructed to stop LDN 10 days prior to a recent surgery because they managed her post-op pain with a lidocaine drip, was told not to restart LDN for 10 days afterwards. She'll be having another, I'm assuming this is a woman, so it says I, but she will be having another lidocaine drip the week following her surgery for chronic pain. Do these two work on the same receptors? And does she need to stop the LDN for 10 days prior to any more lidocaine drips? She did have a ketamine, methadone, lidocaine, propofol induction cocktail with her surgery, and she's had opioid-induced hyperalgesia and fibromyalgia. Okay.
All right.
No.
Yeah,
No,
30
that's-
seconds. That's all we can give you, Pradeep.
Okay, yes,
All
for
right.
Chopra.
Number one, I'm going to take it piece by piece. So the whole concept of stopping it 10 days ahead doesn't make sense.
Okay, that's
You
one.
really just have
Good.
to stop it 6 hours, or to be safe, I tell them stop it 24 hours ahead. That takes away any confusion about it. And then what I tell them is that stop it 24 hours before your surgery, and then restart it 24 hours after your last opioid dose, just to keep things clean. The whole concept of giving lidocaine infusion, and I'm not even sure what they're trying to achieve with that. And then she had opioid hyperalgesia.
Yes.
Well, that is a real thing, but this just
And
we
FMS.
with
Fibro-
MS.
With fibromyalgia.
With fibromyalgia, yes, that is opioid hyperalgesia is a concern, and that's where we talked about the glial cell activation, where opioids can cause glial cell activation. But again, if you're treating this pain, you don't want to be on methadone, you want to be on the LDN part of it. Choose one, but you can choose both.
Okay. I have a very lengthy question here that deals with restless leg syndrome. Unfortunately, it does not ask a question directly associated with naltrexone, so I'm going to have to bypass it. I apologize.
Can I just make a comment on the
Please,
on
go
the
right
operative
ahead.
case? Patients who come to me and are likely to have surgery who are taking naltrexone, and I do a lot of ketamine infusions in my office, I will tell them to inform me if they're going to have surgery so that I can contact the anesthesiologist and tell them to give them ketamine both intraoperatively and postoperatively to try and reduce the likelihood of especially complex regional pain syndrome. I see a lot of those patients, and they are being treated with naltrexone. It really reduces the likelihood of them having to have a recurrence of complex regional pain syndrome in the postoperative period and makes life a lot easier. And I also request the anesthesiologist to limit the amount of opioids, if they can, in the immediate postoperative period. So that combination works. That's not that they don't use the opioids, just use a little less. So they have intravenous acetaminophen, which can be used to try and reduce the likelihood of opioids. They can do various blocks and stuff like that. And that seems to help the patients in that way.
Thank you. I have a question here, which I think we'll hold off for the afternoon Q&A regarding pharmacokinetics and pharmacodynamics. That'll be Stephen Dixon. Yes, you can answer those. I think we addressed this briefly earlier. Is there any information about combining LDN and cannabis oil, CBD? Dr. Chopra, I think you addressed that. Oh, no.
Yes, I did. And this is absolutely, I think it makes great sense to use the two of them together. Number one, they don't interact. That's the first thing. What are the, and this is no studies to show that, but we do know that cannabis has a cell healing property, or I should say it's been used for cell healing properties, tissue healing, as well as, and now we know LDN does that too. So it's a no-brainer to use the two of them if you need it. Cannabis can be used for other things, whatever the reason is. I mean, it's used for seizures, it's used for pain, it's used for lots of things. But using LDN with it is not a bad idea.
Okay. I think Dr. Khan addressed this previously. Can you take LDN with mainstream traditional chemotherapy, and you felt that that was contraindicated or limited value?
Well, it's safe to take it with chemotherapy, but we don't know if the chemotherapy is going to reduce the effect of the LDN. That's what I believe, because the chemotherapy is so severely immunosuppressive that whatever immune benefits you're going to get from the LDN will be diminished or negated.
I think I'd probably lean using the CBD in conjunction with it instead, the cannabis in conjunction instead. Is the LDN a long-term or lifelong treatment for these patients in either case? Dr. Khan or Dr. Chopra?
Well, for cancer, we do keep them on it. Even if they're in remission, we actually do some advanced monitoring to see whether they still have cancer or not, because looking at a scan and saying, well, you're cancer-free is really not adequate. So we look at circulating tumor cell counts, and now we're looking at actually a circulating protein called ENOX2, which is extremely sensitive. And if we find still tiny amounts of cancer in the body, we'll definitely keep them on the LDN for prolonged periods, for years or potentially for lifetime.
Dr. Crowley?
Yeah, I've just noticed that people who've had cancer and who know about LDN, they're requesting to go on it, even though they've had their operation, they're clear, they say, but 3 or 4 years later they come back and they're looking for LDN just to prevent it in the future, because I'm just finally retired after being a GP for 43 years in Ireland, and the rate of cancer is increasing, it seems, and particularly in younger people, and the repeat episodes of it. Now you can blame, I don't know, in Ireland we're thinking it may be what's in the food and the stuff that we don't know, but the thing is, it does seem to come back very, very frequently at 5 or 6 years, and people don't expect that, and it's back. So some people are now saying, well, let's take LDN, and then it won't come back.
Yeah, I think that's a great idea to take LDN as a sort of prevention, but then also, this is very off-label, and it's a radical shift in our approach to cancer, which is to not just accept a scan and say, oh, you're clear, you're cancer-free, because many of those patients are not cancer-free. So we really need to look at more advanced tests that are available, but that are not standard, to see, do they have cancer or not, and at even what level you can even measure it. So we do that with blood tests now, and they are available.
Thank you. During the break, we had one of our participants brought up a comment. There was a question about the incidence of shoulder pain in conjunction with LDN, and I think was it you, Dr. Khan? Okay. In her practice, she had a very interesting theory, and I can't really argue with it. She felt that it was her experience is possibly a Herxheimer reaction with the LDN. So a Herxheimer reaction is a type of mild allergic reaction, for lack of a better description. You know, if anyone wants to address that with better description, please feel free. But she felt that that was possibly the association there. It leads to this actual next question I have here. Essentially a case study. A woman with chronic pain taking LDN for 30 days experiences flat hives on her chest and tops of the thighs, which are more evident in the morning. Is this possibly an allergy or a detox? And is it still okay to take the LDN? Anyone?
Yes.
Dr. Chopra?
So one of the things about drugs is that, you know, in part of some of the large majority of the patients that we see, we have this problem with something called mast cell activation syndrome. This is not that, but we're starting to see people reacting to fillers in drugs. There are preservatives, there are binding agents, and then there are coloring agents and all kinds of stuff, what we call as the inactive ingredients. Before I decide a drug that's as important as LDN, if they're actually having an allergic reaction, I try to talk to the pharmacist about changing the fillers in it or changing the ingredients in it. And I know Skip does that a lot, and Dr. Lenz does that a lot. They change the inactive ingredients to work with the patient. For example, gluten-free LDN, or using, I believe, mannitol in it. But anyway, so she might be having an allergic reaction to one of the inactive ingredients. I would not stop the LDN. I would just simply change the formulation.
Okay. We only have about 3 minutes left before the break. So unfortunately, some of these questions are wonderful questions, but they don't pertain to LDN. And that's because we have such a knowledgeable group of panelists here who presented this morning. Questions for Dr. Khan about metformin, the mechanism of action. Questions about the combination or the similarities between LDN and opiates and cannabinoids. Just wonderful questions, but unfortunately, I can't present them here directly. So I encourage you to try to corner these experts at some time this weekend. That's good. Okay. Here's a real simple one. I've got a 2-minute answer. I've noticed sports. I've noticed a much quicker recovery time, as in less soreness after strength training since starting LDN. Are sports medicine doctors using LDN to enhance athletic performance? If they are, it's probably not going to show up. Anyone? Okay, I thought it was interesting. Probably none of you are qualified to answer this question. Is LDN indicated in dogs for similar conditions as humans? Linda, do we have any veterinarians coming this weekend?
Actually, I do have
Pradeep,
some experience.
Oh, my goodness.
Yes, I do. There are two things that happened. One of my patient's mother is a veterinarian, and we've been trying LDN on her daughter and all that, and then she started using it in her practice for cancers in dogs. And same thing, she's getting amazing results with it. I did it on my dog, and I had a golden retriever, had this really aggressive cancer. It was an angiosarcoma. Not expected to live more than 6 months. I put her on LDN right away. She survived 2 years. So I don't know if that means anything, but it's definitely worth giving your pet a LDN. That's fine.
Thank you.
What dose was the dose given for that?
Doctor, if you pull the microphone towards you, please.
What was the dose given for the veterinary cases?
It was the same 4.5 milligrams.
Dogs do have a different metabolic rate than humans. I'm finding that I think my colleagues who are pharmacists in the audience might differ with that opinion a little bit. But again, we've come to our break. It'll be 1.5 hours. So here, those of us here on the East Coast of the United States, that's 2:30. We'll resume. Those of you who are around the world in other time zones, that's 1.5 hours, 90 minutes from now. We